Welcome to this comprehensive explainer on neuroanesthesia. Today, we're going to dive right in and meticulously decode patient risk assessment plus the 13 specific parameters you absolutely have to manage in the operating room. You see, neuroanesthesia is this incredible high-stakes balancing act. Even millimeter shifts in pressure or tiny changes in temperature can dramatically alter a patient's outcome. Because of that, we're going over this point by point, and we aren't skipping a single critical detail.
To make sure we clear up every concept, we're moving systematically through 5 distinct chapters: assessing risk via ASA classification, managing vitals and gases, metabolism and blood composition, controlling intracranial pressure, and finally, patient positioning and recovery.
Let's jump straight into Section 1, assessing risk using the ASA classification.
Now, the risk of anesthesia escalates significantly across these patient classes. As you can see, you can track it directly, starting from a normal, healthy Class I patient all the way down to a moribund Class 5 patient, which is someone not expected to survive 24 hours. Take a look at the data here. A Class 5 patient faces a staggering mortality rate of nearly 51% at 7 days. It really puts the stakes into perspective, doesn't it?
Moving right along to Section 2, managing vitals and gases.
Our very first parameter is blood pressure. This is the primary determinant of cerebral perfusion pressure, or CPP, along with spinal cord perfusion. In the OR, you're going to frequently manipulate this, maybe reducing it for aneurysms or increasing it to help with collateral circulation. But here is the crucial takeaway for intracranial procedures. Your arterial line must be calibrated directly at the external auditory meatus. Why? Because that specific level most accurately reflects the actual intracranial pressure.
Now, parameter 2 is directly related to that pressure we just talked about, jugular venous pressure. This is one of the main physical factors that influences ICP. You absolutely must respect venous outflow. Think about it like a plumbing system. If there's any obstruction here, it backs up the whole system and dangerously raises the pressure inside the skull.
Up next, parameter 3. Arterial CO2 tension is quite literally the single most potent cerebral vasodilator we have to consider. This is a real game changer because you can use hyperventilation to induce hypocapnia, essentially blowing off that CO2. This safely lowers cerebral blood volume and blood flow. When doing this, your target goal is an end-tidal CO2 of exactly 25 to 30 millimeters of mercury, keeping PaCO2 around 30 to 35.
Parameter 4 is arterial oxygen tension. So while CO2 acts as your lever for controlling volume, O2 tension is your fundamental baseline. You have to meticulously maintain this to make absolutely sure the brain tissue remains well oxygenated. This continuous monitoring is what prevents ischemia throughout the entire delicate procedure.
That brings us to Section 3, metabolism and blood composition.
Let's look at parameter 5, hemocrit. This presents a really fascinating clinical balancing act. On one hand, you absolutely need the oxygen carrying capacity of the blood, right? And that capacity drops if there is anemia. But on the flip side, you also need excellent blood rheology or flow. If the hemocrit gets too high, the blood gets thick and sluggish, which impairs flow to those incredibly delicate microvessels in the brain.
Parameter 6, patient temperature, involves some genuinely fascinating math. Inducing mild hypothermia actually provides powerful protection against ischemic injury. It does this by dropping the brain's metabolic rate of oxygen consumption, or CMRO2. Get this, it drops by about 7% for every single degree Celsius the body temperature falls.
For parameter 7, blood glucose levels, strict vigilance is absolutely required. You just cannot let the patient run hot on their sugars. If a patient experiences hyperglycemia, it actively and severely worsens any ischemic deficits the brain might suffer during the operation.
Building right on that, parameter 8 is the CMRO2 itself. Lowering this cerebral metabolic rate of oxygen is essentially your primary shield against brain injury. You can achieve this critical reduction through a combination of specific neuroprotective agents and, of course, that targeted hypothermia we just discussed.
Okay, moving to Section 4, controlling intracranial pressure. Parameter 9 is CSF output. Managing cerebral spinal fluid is a highly practical lever. If the surgical team has placed a lumbar or ventricular drain, well, that gives you a direct mechanical valve to modulate intracranial volume. It's straightforward. You drain the fluid, you lower the pressure.
Now, parameter 10, head elevation, comes with a very direct physical trade-off. Think about it. Lowering the patient's head increases the arterial blood flow up to the brain. Sounds good, right? However, it simultaneously and dangerously impairs venous outflow back down to the heart, and as we know, that actively spikes the intracranial pressure.
Parameter 11 deals with intravascular volume, which requires extreme caution. On one hand, hypovolemia impairs necessary blood flow, but if you overcompensate with excessive fluids, especially when the patient is in the prone position, it causes severe facial edema. That facial swelling is a major risk factor for PION, or postoperative ischemic optic neuropathy, which can literally lead to blindness. So balance is everything.
This brings us to our final chapter, Section 5, Patient Positioning and Recovery. For parameter 12, we need to remember not to lose the forest for the trees. When you're busy managing complex hemodynamics, it's easy to forget that physical positioning injuries can happen completely unnoticed under all that heavy, opaque surgical draping. Because of this, it demands frequent, proactive physical checks of the patient's positioning by the anesthesiologist throughout the entire surgery.
Finally, our 13th parameter is PONV, or postoperative nausea and vomiting. The sheer physical act of vomiting will dangerously spike intracranial pressure. Not to mention, it can completely ruin delicate cervical procedures that were just completed. To prevent this, you absolutely must actively avoid certain emetic anesthetics, or proactively pre-treat the patient. So after reviewing all 13 of these interconnected clinical parameters, you can see how neuroanesthesia is an incredibly complex balancing act. Fixing one problem can easily trigger another. With all these dynamic factors at play, I want to leave you with this question. Which single parameter do you think leaves the absolutely tightest margin for error in the OR? Think about that and keep exploring.